This is the first presentation in a series addressing the anatomy of the alimentary system. It is going to involve the mouth and salivary glands. This is me as a contributor of anatomy to the alimentary system in semester 1 2020 and 2021. Do not study anatomy without an image or something talking to you. You listen and you write down your observations. The science you are studying to become a doctor is yours. It is not anybody's else. So work on it now and make it shine. How do I do that? You start with a primitive small idea, you work on it and make it bigger and bigger until it shines. When it shines, this means that you have acquired an understanding, and the bright light of shiny ideas never fade away. Remember that at this point of time of the 21st century, science is everywhere. It is in your book, in your phone, in your laptop, in your iPad, in your tablet, and any question you have, you can get access to answers through using these instruments. And remember, the bottom line is science is everywhere. Did you know that the mouth tells a lot about the health of a person? And this is a basic fact, and it is very worthwhile to ask any patient to open the mouth. Here is a basic fact. 90% or more of all systemic diseases have some influence or some manifestation in the oral cavity. So it is very worthwhile to ask any patient while doing physical examination is open the mouth, have a look. It takes few seconds. When you ask a patient to show you the tongue, you can see here that the lips have a normal color and the tongue has normal features and color. This is a normal finding in normal people. While in this patient, when was asked to protrude the tongue and open the mouth, it is obvious that this image is telling me that the color of the lips and the color of the tongue is pale. This is a sign of anemia. When this person was asked to show you the tongue, when the tongue was protruding, it deviated to the left of the patient. Now this has a story, and we will be telling this story in a short while in more details. When you look at this patient, you can see that is showing an ulceration and a fissure at the angle of the mouth. Although the lips have a normal color, but this is a condition called cheilitis, and it is one of the manifestations of certain type of anemia. What is this image telling me? It is telling me that the tongue has patches of very red beefy color, and you can see that part of the tongue is reflecting the light, so it is a bit shiny. What is the story of this patient? It is usually a manifestation of pernicious anemia presented on the tongue. Now, you had your hemolymphatic system, and you should know what is pernicious anemia. This tongue is also beefy red, but very red, and you can see the reflection of light from the tongue. This is a more severe case of pernicious anemia. What is this tongue telling me? It is telling me that this tongue is coated with whitish, yellowish, thick layer of coatation. This is one of the manifestations of uremia, problem of the kidney. If you look at your left, you can see a tongue that is smooth and shiny, and if you look at the center of the mouth, you can see horizontal fissuring. Now, if you want a hint what is this manifestation, it is present in this image of a neutrophil when there is hypersegmentation of the neutrophils. This is caused by something I am sure you already know, but you need some activation of your hemolymphoid system. Here is an image of what is called geographic tongue. It is certain areas of the tongue that get inflamed, and then it spreads in a fashion described as geographic. This is an inflammatory condition of the tongue. Look at these two images. The one on your right looks very normal tongue, while the one on the left is dramatically fissured. This is not a serious condition. It can happen in certain people. No pathological lesion has been found, and this is called fissured tongue. The mouth is full of microbes, whether bacteria or fungi, and they are in balance with the immunity of the body. If the immunity is going to get low because of a disease or because of abuse of antibiotics, here the fungus has flourished, and this is a case of oral candidiasis. The cause is Candida albicans. Here are two ulcers on the inside of the lip, and they are common and they are very painful, and they usually appear after a fever, and when the fever stresses the body and the immunity of the body, or in cases of being sad or depressed, the immunity is going to be affected, and these ulcers appear on the inside of the mouth. They are called aphthous ulcers. I'm showing this another image of aphthous ulceration because I don't want you to get the impression that it is only one or two. Sometimes they are extensive and they are very painful. The patient will be suffering. They cannot eat or drink because of the pain. When you look at this tongue, I'm sure you can recognize that this area is not a good area. It is a bad area, where you can see that the surface of the tongue is irregular. Some areas are coated, it is elevated. This is a mild image of cancer of the tongue. Cancer of the tongue can be very nasty, and there are very ugly images, and I have decided to show you this less ugly image of cancer of the tongue. The bottom line of the previous slides is that there is a subject called oral manifestations of systemic disease. Systemic diseases like what? Endocrine problems, blood disorders, immune deficiencies, treatment of cancer, side effects of drugs, and other systemic diseases. After this exploration of few examples of what can happen to the mouth and the tongue in different diseases, now what do I need to know? The need here is very important knowledge, and that is lymphatics draining the tongue and the mouth, and therefore you need to activate your prior knowledge of the hemolymphoid system, especially the subject of lymph drainage of the head and neck. Although different parts of the oral cavity and the tongue will drain to certain areas of the lymphatic system and to certain regions of lymph nodes, but in a summary, and the basic information is that most of them, and I'm not saying all of them, most of them, they will spread to the submandibular lymphatics and lymph nodes. While you activate your knowledge of the local lymph nodes of the head and neck, you will come to ask yourself, which group of lymph nodes are these? These are the submandibular lymph nodes. What is this image telling me, and what questions I should ask myself? First of all, if I look at the tip of the tongue and the most anterior part, then microbes or cancer or anything that spreads through lymphatic vessels, they will end up in the submental lymph nodes. Where are the submental lymph nodes? They are in the submental triangle, the most anterior triangle of the neck. Then the middle part of the tongue and the mouth, when there is a microbe or a bad cell, these will drain into the submandibular lymph nodes. Where are the submandibular lymph nodes? They are in the submandibular triangle. I will be reminding you of this triangle in next group of slides. Then the posterior part of the tongue. The problem of the posterior part of the tongue is that it is in the oropharynx, and it is very hard to see. So if there is a problem in it, it is usually discovered late, and the lymph nodes draining this area is going to be in the superior deep cervical lymph nodes. This area is covered by a muscle that is the sternomastoid, and these lymph nodes, they lie on the wall of the internal jugular vein. What is this examination? This is an examination of part of the lymph nodes of the head and neck. Which group is being examined? The answer is to go and look for the tips of the fingers of the examining lady doctor. Where are the tips of her fingers? They are near the midline and anterior. Therefore, this is a trial of palpating the submental lymph nodes. What can I learn from this image? I can see that the fingers of the examiner are just deep to the margin of the mandible. It is not near to the midline, and this area is called the digastric triangle or the submandibular triangle, where one can find the submandibular lymph nodes. This is a skill you are going to learn in the future. What am I seeing in this image? I'm seeing that the examining fingers are trying to palpate lymph nodes along the anterior border of the sternomastoid, and in this area, deep to the sternomastoid, there is the carotid sheath containing the common carotid and the internal carotid and the internal jugular vein. So this is a skill of physical examination of deep cervical lymph nodes in the anterior triangle. Again, trying to learn what? To learn skills that involve the location of the regional lymph nodes of the head and neck. Now, the examining fingers here, the tip of the fingers are superior to the clavicle, and there are groups of lymph nodes called supraclavicular lymph nodes. Why should I examine these lymph nodes? Because I want to know how extensive the disease is. If there is submental or submandibular, then I have to go to the deep cervical. If there are large lymph nodes in the deep cervical, I have to come to examine the next stage of spread, which is the supraclavicular lymph nodes in the supraclavicular fossa. This is the bottom line of which area is drained by which lymph nodes. It is an old knowledge when you had your hemolymphoid system, especially the regional lymph nodes. You can go through them and they are colored, and there is attracting attention of the area and lymph nodes. This is an image of a normal, widely opened mouth. So let us ask ourselves a few questions so that we can extract lots of data. First of all, this arrow is pointing at the upper lip. When the mouth is closed, the upper lip and the lower lip, they touch each other, and the space between them is called the oral fissure. And deep to the lips, we can see the arch of a teeth. This is the upper arch of the teeth. The teeth are attached to alveolar process of maxilla, and the lower teeth are attached to alveolar process of the mandible, and there is a space between the lips and the arches of teeth. This is the vestibule. Now, what is the vestibule? The vestibule is a space. It is rather potential space. It is not open. Usually the cheek are stuck to the arches of the teeth, and the vestibule is a space between the cheek and the teeth. The floor of the proper mouth cavity inside the arches of the teeth is formed by the tongue, and underneath the tongue there are two muscles which we will address a little bit later. Then the roof of the proper mouth cavity is made by the palate. The palate has two parts. The anterior is hard palate made by the maxilla and the palatine bones, and the lateral wall of the oral cavity is made by the cheek, one on the right and one on the left. What makes the cheek? The cheek is made of a muscle called the buccinator, and usually there is a pad of fat. Now, if you go deep into the mouth cavity, there is a gate to the oropharynx. This gate to the oropharynx, which is having two lateral borders made by the arches of the soft palate, and in the middle redundant uvula. This is the fauces. Here is another view of a widely opened mouth, and we need to ask a few questions to extract some information out of it. Now, the first question is why I am presenting this image. I am presenting this image because the upper lip and the lower lip are pulled up and down so that you can see the space of the vestibule, because it wasn't very clear in the previous slide. In the previous slide, the lips were stuck to the arch of the teeth, and here it is pulled so that you can see that there is a space between the lips and the arches of the teeth. And also you can review the other features which are labeled on the sides of the image. What is this image? This is a sagittal view of the mouth, and we can see that here is a space anterior to the teeth. This is the vestibule, and this is the mandible, and this space is posterior to the teeth, and therefore it is part of the proper mouth cavity. The roof of the mouth here is represented by the hard palate. The hard palate, as you know now, is made of the maxilla and the palatine bone. So the anterior part is hard and the posterior part is muscular. Then we come to the soft palate. Here is a question: is the soft palate part of the roof of the mouth? The answer is, let us explain a few facts. The soft palate is a kind of a valve that is going to go up and then comes down, and it hangs down from the hard palate, and during swallowing the soft palate will go up and prevents air from getting down, so that you can swallow comfortably, and it separates the nasopharynx from the oropharynx. So it is more like a valve, and it hangs down. Anyway, some references say that the soft palate is part of the roof of the mouth. Others, they say it is a valve hanging down from the hard palate, and it is movable, therefore it is a muscular organ. We will come into the details of the soft palate in the next few slides. What are the features that can be seen in the vestibule of the mouth? In this view, you can see that the upper lip has been lifted up, and the black arrow is indicating that there is a fold of mucous membrane of the mouth in the middle of the front part of the vestibule, and this frenulum is there to enable the upper lip to function and to stay in normal physiological status. Looking down at the lower part of the vestibule, there is also a corresponding structure to the upper lip, which is indicated by the black arrow. This is the inferior frenulum. It keeps the lower lip in a normal physiological position, and sometimes this frenulum is a bit long, therefore the lower lip will drop down a little bit more than it should be. Again, asking the question, what are the contents of the vestibule? And we already have seen the upper frenulum and the lower frenulum, and at the sides of the vestibule you can see that there is a circular elevated area with a opening in the middle. This is the opening of the parotid gland. Where is this opening? It is to the side of upper second molar tooth. Questions. What is this black arrow pointing at? It is pointing at the upper part of the cheek, where you can see the slight elevation, which is more obvious than the previous slide, and there is an opening in the middle of this what is called papilla, and you can see the opening very clearly. This is the opening of the parotid salivary gland into the mouth opposite the upper second molar tooth. What is this view? It is an opened mouth. You can see the upper teeth and the lower teeth, and to your left is the cheek, and you can see that there is a papilla, and that is the opening of the parotid gland, and you can see some whitish material coming out from the lumen. The normal secretion of the parotid salivary gland is usually colorless, and it is not whitish, so there is something wrong of the parotid gland on this side in this patient. Is there a connection between the vestibule of the mouth and the proper mouth cavity, especially when the mouth is closed? The answer is yes. It is a connection between these two parts of the oral cavity posterior to the third molar tooth. How can we make use of this slide? It is an open mouth with the tongue elevated, and you can see the lower arch of the teeth very well, and we have oral vestibule and oral cavity proper. Which one is which? This is the oral vestibule between the teeth and the cheek, and this is the proper oral cavity inside the arch of the teeth. You can see also the frenulum of the tongue, and on both sides of the frenulum of the tongue, where the mucous membrane is a bit thinner than the dorsal part, and you can see veins in this area. This is called the fimbriated fold. This is a lateral view of the head and neck, and it is showing a muscle part of the cheek. This muscle is the buccinator. The buccinator is a member of the muscles of facial expression, and it plays a role in the process of the normal physiology of the mouth. The normal physiology of the mouth, one of the functions is mastication. Now, mastication has its own muscles, which are the lateral pterygoid, medial pterygoid, the buccinator, and the temporalis, and these muscles are supplied by the motor part of the trigeminal nerve going down through the mandibular branch. Now, these are four muscles supplied by trigeminal nerve, and this muscle is a muscle of facial expression, and it is supplied by the facial nerve. Why does it take part in the process of mastication? It is because it presses the cheek against the teeth, and when it does that, it pushes the food between the teeth so that it can be masticated. If it does not work, then something wrong is going to happen. Fluids and food will collect in the vestibule, and when food is collected in the vestibule, is it going to be masticated? The answer is no. And this muscle takes origin from the pterygomandibular raphe, the mandible, and the maxilla, the posterior part of the maxilla, and then it is going to be inserted anteriorly into the angle of the mouth and the lateral portion of the upper and lower lips, and it is supplied by the facial nerve, the seventh cranial nerve, and not by the mandibular branch of trigeminal. And it is very helpful in the process of mastication, and you need to activate your prior knowledge of the mandibular nerve of the trigeminal and the facial nerve. Here is another view of the head, and putting the buccinator in context. That means the buccinator among its groups, and it emerges from under the lateral margin of the buccinator, and it goes to inserts into the angle of the mouth and superior and inferior lips. That is the external appearance of the buccinator. Another view showing the skull with some of the muscles of the infratemporal fossa, and the red lines leading to the question mark are indicating a muscle of mastication, and that is the lateral pterygoid muscle. And here we have the buccinator coming from the pterygomandibular raphe, and then it is pierced by the parotid salivary gland duct opening into the mouth. Look at this person. This person has facial palsy, and you can see that the mouth is pulled towards the left, therefore the right side is paralyzed. Now we need to apply our knowledge of the buccinator muscle. We have spent 3 or 4 slides explaining the buccinator because it is going to lead us to explain and to apply the knowledge of the buccinator on this patient. What is this patient going to have? Would this person have difficulty drinking or chewing food? The answer is yes. Now, why is that? Think of it. It is because the right buccinator is not working. That's first. The second, is that the angle of the mouth is pulled and the vestibule is opened, as well as the left one. Therefore, the food and the drinks will collect in the vestibule, and the hard food is not going to be chewed, especially on the right side, and the fluids, the water, the juices will be dipping down from the angle of the mouth on the right side. Therefore, our knowledge of the buccinator will help us understand the complaint of this patient when he says that I cannot eat well anymore. So this is collecting knowledge and then applying it on patients. This is an opened mouth, and we can see that the floor of the mouth is made by the tongue. Now, in this view, the tongue is protruding out, and we can see that there are two black arrows indicating an elevated little swellings. These are called circumvallate papillae. They are full of taste buds. Now, is this all what we see of the tongue? The answer is no. The tongue is usually divided into anterior 2/3 and posterior 1/3. Here is the anterior 2/3, and the posterior 1/3 is difficult to see because it is in the oropharynx. And another feature is that what separates the anterior 2/3 from the posterior 1/3? The answer is sulcus terminalis. It is V-shaped. It is inverted V-shaped sulcus that separates the anterior 2/3 of the tongue with the posterior 1/3 of the tongue. What is this? This is a closer view of the tongue, especially posterior part of the anterior 2/3 of the tongue, and the circumvallate papillae are quite clear here, and they are at the border of the two parts of the tongue. The black circles, they are showing other forms of taste buds, the fungiform type of taste buds. This is a diagram of the two parts of the tongue, and what do I see? I can see that this is the anterior 2/3 of the tongue, which has its own appearance, and you can see that there is a median furrow indicating the septum of the tongue, because the tongue is made of the right and left halves. And then the posterior 1/3 of the tongue, which is in the oropharynx, is having its own appearance, and this part of the tongue contains many lymphoid follicles, and it can be rightly called lingual tonsils. And you know from your hemolymphoid system what is a tonsil. And then we have at the middle of the sulcus terminalis we have a remnant of a foramen, and this foramen is going to give rise to the beginning of the development of the thyroid gland. And these yellow lines are indicating the sulcus terminalis. And on both sides of the lingual tonsils, you can see that at the sides there are the palatine tonsils, and this is the palatine tonsil. What is this view? This is a widely opened mouth with the tongue elevated, and when it is elevated, the frenulum, which is marked number 1, is showing very well. Sometimes this frenulum is short, and therefore the person has difficulty chewing food and difficulty pronouncing some letters. And the blue arrows are indicating the openings of the submandibular salivary gland, which are called the Wharton's ducts, opening on both sides of the frenulum. What is this diagram showing? It is a diagram of the tongue with a coronal section, and it is showing the muscles of the tongue. What is the best description of the tongue? It is a muscular organ, and there are muscles inside the tongue that is going to change the shape of the tongue according to the physiological needs, and there are extrinsic muscles that will move the tongue as a whole, whether moving it up and posteriorly, down and posteriorly, or down and anteriorly. So the most superior intrinsic muscle is superior longitudinal, coming between the anterior and posterior part of the tongue, and when it contracts, it makes the tongue as a ball. And then underneath it is a vertical muscle, of course skeletal muscle, and this vertical muscle will make the tongue thinner. Then deeper to the vertical is transverse intrinsic muscle of the tongue, and when it contracts, it makes it narrower and longer. And then the fourth layer is the inferior longitudinal. You may notice that there are 2 layers of longitudinal intrinsic muscles, and these are the intrinsic muscles of the tongue. Now, the extrinsic muscles of the tongue, we have pairs, because we have a septum, and the tongue embryologically developed from a right side structures and the left side structures. Now there is the palatoglossus, a muscle coming from the soft palate to the tongue, and then we have the styloglossus, a muscle coming from the styloid process, which is posterior and higher up, and when this styloglossus muscle contracts, it is going to pull the tongue up and posterior. Then we have the hyoglossus muscle. As you can see, the fibers are long, and this muscle takes origin from the hyoid bone and inserts into the bulk of the intrinsic muscles of the tongue, and it pulls the tongue down into the floor of the mouth. And then genioglossus muscle. This muscle is a special muscle. Why is it special? Because it is bulky. It takes origin from the genial tubercles, which are 4 at the most anterior part of the inner surface of the mandible, and then it fans out to be attached to the tongue. There is a right one and there is a left one. Now, you may have seen or remember an image when a patient was asked to protrude the tongue. The tongue has deviated towards one side. This is because the genioglossus on one side is not working, and if you go and follow the hypoglossal nerve, which is supplying all the muscles of the tongue except one, we will come to it later when we talk about the soft palate, has a special center in the nucleus of the hypoglossal nerve in the medulla. So these are the intrinsic and the extrinsic muscles of the tongue. This is a diagram of the extrinsic muscles of the tongue, and it raises many questions. Which is which? For example, this is the apex of the tongue, and this is the mandible, so this is anterior, and we have a muscle called palatoglossus. This muscle is coming from the soft palate to be inserted into the posterior part of the tongue. Then we have superiorly and posteriorly we have the styloid process, and the styloid process gives origin to a muscle that comes down and then inserts into the tongue, and this is called the styloglossus muscle. Now you know the function of this muscle. It pulls the tongue up and posteriorly. What is next? Next is go to the hyoid bone. The hyoid bone is something you know by now, is within the horseshoe shape of the mandible, and this hyoid bone is going to give origin to a muscle from its body and from the greater horn, and this muscle is going to be inserted into the tongue, and this muscle is the hyoglossus muscle. From the direction of the muscle fibers you can see that it is going to pull down and posteriorly the tongue. Then this muscle here, indicated by the yellow arrows, this is the genioglossus. It is a fan-shaped muscle. It is very important muscle, and it protrudes the tongue there, and it is supplied by the hypoglossal nerve. All these muscles are supplied by the hyoglossus muscle, except the palatoglossus. The palatoglossus is supplied by the vagus nerve, but the bulk of the muscles are supplied by the hypoglossal nerve. That is indicating that the genioglossus is a special muscle, and we use it to test the hypoglossal nerve. This slide is to be left to you to decide and describe what is 1, what is 2, what is A and B and C and D, to practice your understanding. Here is an image of blood supply to the head and neck, and we were concerned about the tongue, and we described the tongue as a muscular organ, and then muscles need blood supply, and the tongue is going to be supplied by a branch of the external carotid artery called the lingual artery. The lingual artery is a branch of the external carotid. It is the second one. The inferior one is the superior thyroid. The second is the lingual, and then superior to the lingual is the facial artery. The tongue is not only supplied by the lingual artery, it is mainly the lingual artery. It also gets help from two other arteries, and you need to think about which arteries are going to add to the lingual artery. The logic says, of course, it is coming from arteries of the neighbors of the tongue. So what are the neighbors of the tongue? Which arteries supply these neighbors, which then are going to give a branch to the tongue? I'm going to leave you to think of that, and you can find it in the books, no problem, but it is just a bit of little exercise. The conclusion is that the muscular tongue is very rich in blood supply. Now, in the future, where are we going to face this fact? Trauma, of course, is one. The second is epileptics. People with epilepsy, they have tonic and clonic contractions of muscles, and including the muscles moving the mandible, and they may bite their tongue, and it is going to bleed, and bleed a lot, or they may even cut part of their tongues. So we know now that the tongue is very well supplied with blood, and whenever we see an epileptic patient having a fit, it is very important that we put a piece of plastic or plastic bar and push the tongue in and put the plastic bar between the teeth so that the patient will not bite the tongue and then bleed a lot. Okay, what is this image showing me? Here is the origin of the lingual artery coming from the external carotid, branch of the common carotid. This is the branch going down, and this is the superior thyroid artery, and this is the lingual artery, and the next higher up is the facial artery. And the lingual artery is quite sizable artery. It goes into the inferior part of the tongue, and then it sends branches to the muscles of the tongue. It's time to talk about the sensations of the tongue. The tongue is the organ of taste. It is the only place where you can find taste buds. There is a somatic sensation, that means the feeling of touch, temperature, and somatic sensations, and the anterior 2/3 are carried by the lingual nerve, a branch of mandibular, a branch of trigeminal, and the posterior 1/3 is by the glossopharyngeal nerve, because it is lying in the oropharynx. And the anterior surface of the epiglottis, there are also taste buds, fewer in number, and these are carried out by the vagus nerve. Then we turn to taste, the special visceral afferent sensations. The anterior 2/3 has a story. The sensations from the taste buds, they travel through the lingual nerve, and then they leave the lingual nerve and form a nerve called chordae tympani, and this branch is going to join the facial nerve, and they will end up in a nucleus called nucleus and tractus solitarius. So it starts in the lingual nerve, leaves the lingual nerve, and joins the facial, and you need to activate your knowledge of the distribution of the facial nerve. Now the posterior third, the taste is carried out by the glossopharyngeal nerve, and then the anterior surface of the epiglottis sensations are carried by the vagus nerve. Here is a problem. This patient was asked to protrude the tongue, and the tongue has deviated to the left. Now we need to go to the basics. What are the basics needed in this case? First of all, the tongue is made of two halves, a right one and a left one, and there's a septum in between. The tongue has intrinsic and extrinsic muscles. Now, which muscle is going to protrude the tongue? It is the genioglossus muscle. It is a fan-shaped muscle coming from the genial tubercle anteriorly on the inside of the very front part of the mandible, and then inserts into the intrinsic muscles of the tongue, and it is a bulky muscle. What is the nerve supply of this genioglossus muscle? It is the hypoglossal nerve. Where is the nucleus of the hypoglossal nerve? It is in the medulla oblongata. Now, these are the basics. Let us explain what is happening, and when this tongue protrudes deviating to the left, which part or which hypoglossal nerve is affected. Let's see more details. Here we have two diagrams. Let's look at the left one. In the left one, the patient was asked to protrude the tongue, and this is an active process including the hypoglossal nerve and the genioglossus. Now we have two hypoglossal nerves and two genioglossus muscles, and they contract at the same time, the right and the left, and they coordinate and balance the tongue, and the tongue is protruding exactly in the middle. This is what happens normally. Now, in case of active protrusion of the tongue, that means you ask the patient to protrude the tongue and it deviates. That means that one of the hypoglossal nerves has a lesion. Now, how do we explain that? And we need to know the tip of the tongue is pointing at the affected side or the normal side. Now, here is the analysis. In this tongue, the right genioglossus muscle is working all right, and it attempts to protrude the tongue. The left genioglossus muscle is not working, therefore it does not balance the right one. Therefore, the tip of the tongue is going to be deviated to the left, because the left is not working and the right one is working well. Therefore, in this case, the tip of the tongue points at the affected side, the paralyzed genioglossus side, and the tongue deviates and points to the affected side. This view is an inferior view, and you may remember that we said that the floor of the mouth is made by the tongue plus muscles inferior to the tongue, and one of these muscles is a muscle coming from the hyoid bone and attaches to a line on the inside surface of the body of the mandible, and this muscle is called the mylohyoid muscle. The nerve supply of this muscle is coming from the inferior alveolar nerve, a branch of the mandibular of the trigeminal nerve. What is this view? This is a diagram showing an inside view of the mouth after not showing the tongue, and this is the muscular floor of the mouth, formed by, first of all, this muscle here, and inside this circle you can see 4 genial tubercles in the anterior part of the inside of the mandible, and the superior genial spines, or also called mental spines, will give origin to the genioglossus. The inferior 2 are giving origin to a muscle extending from the inferior genial tubercles to the hyoid bone, and this muscle is the geniohyoid muscle. It usually elevates the hyoid bone. And the next muscle, the broad one that we have just seen in the previous slide, is attached between the hyoid bone and the mylohyoid line on the inside of the body of the mandible. That's the mylohyoid muscle. After looking at images of different kinds and asking questions and collecting data, we should do what doctors do. We should stop, think, and write down our basic knowledge. You can follow the lines extending from the center to the periphery, and you may remember that the center will lead us to the periphery. The periphery includes details, and usually the devil is in the details. If you follow the line, the red line coming down towards the lower and right part, which is talking about blood supply, and you can see that the blood supply is mainly by 2 lingual arteries coming from external carotid, plus 2 smaller branches, which I described as coming from the neighboring organs, and the neighboring organs to the tongue, of course, they are the tonsils. So you get branches from the tonsillar artery and branches from the ascending pharyngeal arteries. All of them are branches of the external carotid. So when I asked you to look for the extra 2, here is the answer. If you follow the sensory nerve supply, and you can see a summary of the basics and so on. What is this view? Now we have left the tongue and we are approaching the inner side or the posterior part of the mouth, and we can see that the roof here, the anterior part of the roof, is the hard palate, and then we are going to talk about the soft palate. You can see that the soft palate is hanging down from the hard palate. I'm sure by now you know what is this image. It is an image of the roof of the mouth made by the hard palate, and the most anterior part is made of parts of the maxilla, and the maxilla sends horizontal processes making the roof, and these horizontal processes are called the palatine processes of the maxilla. Then the most posterior part is made by the palatine bone, and the palatine bone sends processes called the horizontal plates of palatine bone. This is a close image of a living person, and you can see the hard palate inside the arch of teeth, and the mucous membrane here has special features, and these features are folds, transverse folds called corrugations of the mucous membrane of the hard palate. Now, this mucous membrane has special features, and it is very adherent to the periosteum of the underlying bone, the periosteum of the palatine processes of the maxilla, and therefore the mucous membrane here is called mucoperiosteum. They are very adherent and very difficult to separate, and there are lymphoid follicles in these corrugations. What is this? Here is a closer image at the soft palate, and there is a junction between the soft palate and the hard palate. When the hard palate ends, the soft palate is attached to its posterior margin, and this is the soft palate here, and the soft palate laterally has two extensions. This one here is the anterior one, which is called palatoglossus, and there is a posterior one called palatopharyngeus, and in between these two arches we have the tonsillar fossa, and in the middle we have the dangling down muscular part of the soft palate called the uvula. It is worth mentioning that the soft palate, the same as that of the tongue, is made of two halves, a right one and a left one, during early development, and they develop, and before birth they join and form a fully functional soft palate. This is a closer look at the posterior part of the mouth, where you can see a close view of the soft palate, which has the typical signs of inflammation. You have redness, you have dilated blood vessels if you look very closely, especially at the sides of the soft palate, and you can see whitish spots. These are collection of pus as a result of inflammation. This is bacterial inflammation. If it is viral, you cannot see white spots, and this is a severe case. Even there is a spot of petechiae, little hemorrhage at the top left part. And do you know what is this condition called? It is not called palatinitis or anything. It is called pharyngitis. Wow, what is this? This is a case of a patient who has a problem. The problem is in food intake, and we asked the patient to open the mouth, and what do we see? We see that the uvula is not in the center. The uvula is deviated towards the right of the patient. Now, what do we need to know about this case? We go to basics. This is one of the rules we have been following. The basics are as follows. First of all, the soft palate is made of two halves, a right one and a left one, And the soft palate is a muscular organ, and it is made of voluntary muscles, and the nerve supply of these voluntary muscles come through the vagus, and you can see that one side is not working. Now, which side is not working? It is the left. Why? Because the uvula is deviated to the right. When there is a deviation to the right, that means the right is working, and the left should work and bring the uvula in the middle. It is not working here, therefore it is the left. What is this image showing me? First of all, this image is going into the mouth very close to the uvula, and you can see the soft palate hanging down, but the uvula is bifid. It is not one single dangling muscular structure. It is bifid. What is the story here? The story here is by going back to the basics, which are the soft palate is made of two halves, a right and left one, and they join, and the process of joining is completed 100%, and the uvula is a single structure. Here is a patient. When was asked to open the mouth, we can see that there is a gap between the oral cavity and the nasal cavity, and the palate, the hard and the soft, coming from the sides, they stopped. They should continue and meet in the middle. So what do I need to know? I need to know the development of the palate, the development of the head and neck. Here is a diagram analyzing the structure of the soft palate. What makes the soft palate? First of all, there is a muscle called tensor villi palatini. This is a muscle that makes the skeleton of the soft palate. As it comes from the base of the skull, it changes to a tendon and hooks around the pterygoid hamulus, the hamulus of the lateral pterygoid plate of the pterygoid process of the sphenoid bone, and as it hooks around this hamulus, it is going, that means the tendon, it is going to approach the midline and meet the similar muscle of the other side. This muscle, the tensor villi palatini, is going to make the skeleton, the basic structure of the soft palate. When these two tendons, the flat tendons of the tensor villi palatini, they meet, they make a structure called palatine aponeurosis. And the palatine aponeurosis is the basic structure of the soft palate. Then superiorly, another muscle, it comes from the base of the skull and attaches to the aponeurosis, and this is called the levator villi or villi palatini. It elevates the soft palate so that it cuts off the connection between the nasopharynx and the oropharynx. And then we have two muscles coming down. These two muscles are going to make two arches. Posterior one is the palatopharyngeus, which is going from the soft palate to the muscular wall of the pharynx, and we have the palatoglossus, which is either going to depress or bring down the soft palate, or it is going to lift elevate the tongue for a very short distance. Then we have in the middle the musculus uvula we have just seen, and the soft palate prevents regurgitation of food into the nasal cavity, as well as dedicating the oropharynx for swallowing. What is this view? This view is back into the oral cavity, where you can see the uvula in the middle, and here is the posterior arch, the palatopharyngeus, and here is the anterior arch made by the palatoglossus, and between the two arches there is a space called tonsillar fossa, where you can find the palatine tonsils. And the gate, it's a space, the gate between posterior part of the mouth opening into the oropharynx is called the fauces. This is another look at the same area of the previous slide, and here is the anterior pillar made by the palatoglossus, and this is the posterior pillar made by the palatopharyngeus, and here is the tonsillar fossa, and the gate to the oropharynx is called the fauces. Here is a closer view at the fauces, where you can see that the two palatine tonsils are large, coming from the tonsillar fossa, and you can see the anterior pillar on both sides, but you cannot see the posterior pillar of the soft palate. This is a view of posterior part of the oral cavity, and the patient was asked to say ah, where the soft palate goes into contraction, and you can see that what is in front of you is the posterior surface of the oropharynx. After all these details, one can say, wow, I need to know more. You see, there is a problem, and that problem is that the disease is a devil, and the devil is hiding in the details. So we need to know lots of details. In order for the mouth to function well in receiving food, mixing it, and preparing it for swallowing, it needs to be wet. Not only wet, but the process of digestion is going to start in the mouth. So we need salivary glands. There are major salivary glands which are definite organs. They have their own structure, they have their own capsule and their very specific location, and they have specific, well structured ducts that have an opening into the mouth. These are the features of major salivary glands, and there are three pairs of salivary glands. They are the parotids, the submandibular glands, and the sublingual glands. While the minor salivary glands, they are little collections of glands spread all over the mouth. So this is a resume to summarize the major and basic facts of the process of salivation. And the three major salivary glands are the parotids, submandibular, and the sublingual. These are the major salivary glands. This is a diagram showing the positions of the major salivary glands. Now, this is the parotid gland, which we are going to talk about in details in the next slides, and it has its own ducts. That's one of the properties of major salivary glands, and this duct is called Stenson's duct, and we have seen it piercing the buccinator and opening opposite the upper second molar. Sometimes part of the salivary gland, the parotid, is going to separate from the main mass and makes a little lobule attached to the duct. This is called accessory parotid gland. Then we have the submandibular gland. Submandibular gland, we will go through it in details, and it is in the submandibular region. And then we have the sublingual gland. Do we have problems with salivary glands? The answer is yes, we do. There is a problem, and that is that salivary glands usually have lymph nodes around them, sometimes not around them, in the capsule of the gland, and sometimes inside the capsule. So when we have a little swelling in the area of that gland, we need to ask ourselves several questions to decide whether this is a lymph node or a part of the salivary glands. The best example is that of the parotid. There are, as you may know or remember, that the lymph drainage of the head and neck includes a group of lymph nodes called parotid group of glands, or preauricular group of lymph nodes. Here is a little child, and if you compare the left side with the right side, you can see that there is on the left side swelling anterior to the ear, even extending down. And what do we need to know? We need to know knowledge of salivary gland. This is a case most likely of mumps, which is a viral infection of the parotid gland. Here is another case where when you compare the right side with the left side, you can see that there is a swelling on the left side in the area of the salivary glands, and we do really see people with problems of salivary glands, and we need to know details about them. Here is a lady, an old lady, who has a rather big swelling anterior and inferior to the ear, and this is very likely a problem of the parotid gland, which can affect all ages and all sorts of people. Here is an image of a young man having a rather large swelling in the area of his left parotid gland. Now, as you may conclude now, that diseases of salivary glands can affect all ages and sorts of people. So what do I need? I need to know details. Case presentation of a generally diseased salivary glands. Facial swelling. This is what we have seen in different groups of people. Discomfort. We will explain why there is discomfort. Now, the area is slightly tender. Tenderness is usually a sign of inflammation. Pain increases while eating or drinking because of movements of the temporomandibular joint. There is a close relation between the parotid and the temporomandibular joint. Pain subsides within an hour of eating, and the pain significantly increases with each meal. These are the simple, basic, general complaints of patients with problems of salivary gland. During this presentation, I tried to give examples of problems of the tongue, problems of the mouth, problems of the soft palate and the hard palate and the salivary glands. Because examples, it is not another way to teach, it is the only way to teach. This is a famous quotation quoted by Albert Einstein. This is a cadaveric image of a dissection of the head and neck, and for your orientation to know where you are, to your left you can find the external ear, and to your right the eyes have been blurred, and lower down you can see the mouth. And if you look anterior and inferior to the external ear, you will find the parotid gland. Parotid gland is described as being pyramidal, and what you see is the base of the pyramid, and the tip is going inside between the ramus of the mandible and the mastoid process. And if you look at the periphery, especially the anterior periphery of the parotid gland, you can see these white structures. These are branches of the facial nerve. They are coming out of the gland, and the facial nerve is inside the substance of the parotid, and this is a problem. And if you follow the red arrow, you can see that the duct of the parotid gland goes anteriorly, and it reaches the buccinator muscle and opens into the mouth. This parotid gland duct is called Stenson's duct. Here is another cadaveric image, dissected head and neck, and we need to ask several questions about the features we see in this cadaveric image. If we look into this area, when I say this is anterior to the external ear, and you can see that this is the parotid gland under the skin, and that's the base of the parotid gland, and here is Stenson's parotid gland duct going anteriorly to the buccal area to pierce the buccinator and gets into the mouth. By now you know what view is this, and here is a clear demonstration of Stenson's duct as it goes anteriorly and pierces the buccinator. Now in this patient there is a swelling just inferior to the pinna of the ear. Now that swelling, although it looks simple to you, but to a doctor it looks dodgy or a bit query. Now we need to go into details to find out and solve this problem, and I need more details. I will tell you why. This is a diagram of lateral view of the head. Now the pink structure is the parotid gland, and you follow the borders and you can see that the submandibular salivary gland is just inferior to the lower part of the parotid. Now, the swelling we have just seen is inferior to the ear, and it was around the angle of the mandible. So we need to decide which salivary gland is producing this swelling, and it is a problem. Here we can see the green structure, which is Stenson's duct, as it appears from the anterior border of the parotid, runs on the masseter, and then finds the buccinator and passes through it and opens into the mouth. This is a very similar image to the previous one, and we are going to look into relations of the parotid gland. The parotid gland is anterior to the external ear or to the auricle. It is anterior to the upper part of the sternomastoid muscle, and it is anterior also to the mastoid process, and its lower part is just superior to the submandibular salivary gland, and the parotid extends or covers the posterior part of the masseter muscle, a muscle of mastication, and there is a little extension of the parotid gland separated or attached in a very little way to the parotid gland, and this is usually called the accessory parotid gland. This accessory parotid gland is usually related to the Stenson's duct, and it is inferior to the zygomatic arch. Although we have discussed the external appearance of the parotid gland and its different relations, now I will not comment on this slide, but I will leave it for you to review and look into the details of this image. Now, in this view, I have to stress the fact that the facial nerve, as it comes out of the stylomastoid foramen as a main stem, gets into the substance of the parotid gland, and within the parotid gland it is going to give its 5 branches supplying muscles of facial expression. So if there is a problem or a tumor in the parotid gland, it should be removed little piece by little piece to preserve the facial nerve. Now, this facial nerve is going through the parotid gland and dividing it into superficial and deep parts. This is a cadaveric image of the parotid area, where you can see that inside this oval shape is the parotid gland, and the skin has been dissected and reflected anteriorly, and you can see that this is the stem of the facial nerve, and it gets into the parotid gland. The retractor is pushing the superficial part of the salivary gland upwards to show you the main stem and the different branches of the facial nerve. This is a slide showing you a summary of 4 major relations of the parotid gland. It is superiorly the head of the mandible, posteriorly the mastoid process, anteriorly the middle of the masseter muscle, but the problem is in the inferior relation, which is 2 centimeters below the angle of the mandible. This area, the 2 centimeters below the angle of the mandible, you can find the lower pole of the parotid, you can find the submandibular salivary gland, and you can find lymph nodes as well. So a problem there, we have to decide which structure is involving this lesion, which is not easy. What is this? This is an MRI, magnetic resonance imaging, of a horizontal section in the head, in the parotid area. Now, this green border is around the parotid gland, and this is the parotid gland. There is a little extension that goes medial to the mastoid process, and there is a medial little extension that goes to the pterygoid processes and the parapharyngeal space, and these are the inside structures of the parotid. This is a CT scan of cross-section where you can see the arch of the mandible, and you go lower down the whitish area of the atlas and axis, and on your left the blue marked area is a normal parotid gland, which is related to the external and ear and external auditory meatus, while on your right, the green marked area, you can see that there is a spot of white color. This is usually a stone in the center of the gland. Why should it produce stones? Because it produces a solution, and imbalance in the solution will result in the formation of stones. You have seen similar image of this view, but here the superficial main part of the gland has been removed, and you can see the different branches and stems of the facial nerve. Now these green circles, the one to your left is the part of the parotid that is 2 centimeters below the margin of the mandible, and the one lower down and to your right is the submandibular salivary gland. So if there is a problem in either the lower part of the parotid or the submandibular, then we have to stop, think, and decide where is the problem. Here is a diagram of cross-section of the parotid area, but it contains several useful details. First of all, the facial nerve is passing through the parotid gland. Then the superior end of the external carotid artery, and then if you go higher up, it is the superficial temporal artery, is within the substance of the parotid gland. Then there is a large vein. This is the retromandibular vein. It is also within the substance of the parotid, and it is covered by skin. Then we come to an important piece of information. The parotid gland has its own capsule because it is a major salivary gland. This capsule is made of non-elastic connective tissue. That means if there's an inflammation and the gland wants to expand, it cannot, therefore it is going to be painful because of the pressure on the nerves inside it. Then after you go out of the capsule of the parotid gland, we have another envelope, which is the upper extension of the deep investing fascia of the neck, which splits and envelopes the parotid gland. So the parotid gland has two capsules, its own capsule plus covering of the upper end of deep investing fascia of the neck. The anterior part of the parotid is going to cover part of the masseter muscle the muscle on the outside of the ramus of the mandible. Then it is posterior to the temporomandibular joint. Therefore, problems of the parotid will cause painful opening and closing of the mouth. Plus, the mastoid process is posterior to its posterior part. Then we have the styloid process, which is posterior and medial. The styloid process has muscles and ligaments attached to it. Therefore, it is usually called the styloid apparatus. It is medial to the parotid gland. Then, if you look at the image to your right, it says the pharynx. Little extension of the parotid approaches the pharynx, and there's a space around the pharynx called peripharyngeal space, and you can find part of the parotid gland there. You can see in this cadaveric image that the parotid gland is marked green, and it is anterior to the external ear, going down towards the angle of the mandible, and then part of it is inferior to the lower margin of the mandible, and this is the confusing part if anything goes wrong in this area. When problems happen in the parotid and we want to know whether the duct system, not only the major, the Stenson's duct, but other ducts inside the gland, if we want to check the duct system, we have to do what is called a cyanogram. We put a very small cannula in the papilla of the opening of the parotid gland in the vestibule, and we inject a solution that is radio opaque, and we push some solution, and this is going to show the duct and its ramifications, its branches. Therefore, these ducts inside this yellow oval is ducts within the gland, and here is Stenson's duct going to open into the mouth, and this investigation is called cyanogram, and this is a normal finding cyanogram. After collecting data from the so many slides we have seen, what do doctors do? They stop, they integrate and think about the basics of the collected data, and here is a mind map of the basics of salivary glands. After collecting that data about the parotid gland, we need to stop, organize, and coordinate and integrate the basics of the parotid gland, and you simply follow the colored lines, and everything is in front of you. Now, here is a place of problems when we said that the inferior part of the parotid gland is inferior to the margin of the mandible, and this creates a bit of confusion whether it is in the parotid or submandibular or lymph nodes. Then, if we look at this red rectangle, it says that part of the extension of the inside of the parotid gland is going to go very well related to the temporomandibular joint, and this is called the glenoid process. That's why diseases of the parotid are going to produce painful movement of the temporomandibular joint. Then anteriorly, the superficial part of the parotid gland is superficial to the masseter, and small part of the gland is related to the duct, and this is called the accessory parotid gland. It has a small duct that opens into the major duct. Then you see the capsule, which says that it has an own capsule plus extra one from the deep investing fascia of the neck. If you go and follow structures passing through the gland, the violet color idea, it says facial nerve, and the basic facts about what it does to the parotid gland, and then the lymph nodes, the external carotid artery, and the retromandibular vein. These are collected and organized and integrated basic ideas about the parotid gland. It's useless reading it to you because you can read it your own, and it is so simple, and it is going to summarize everything for you in a way that is easy to read. Here is a problem: a swelling in the neck of this young man, and it is inferior to the lower border of the mandible. It is not near the angle of the mandible, and it is a remarkable swelling. Where is the problem? This is a freshly dissected cadaver, and the green structure marked under the lower margin of the mandible is the submandibular salivary gland. Here is a dissected cadaver, and if you go to the submandibular area, you find this large mass. This is the submandibular salivary gland in the submandibular area. This is a freshly dissected cadaver. Now, to orient yourself, if you look to the upper far right side, you can see the pinna of the ear, and on the upper left side you see the front part of the mandible. And if you go along the inferior margin of the mandible, you can see the submandibular salivary gland in the submandibular triangle. This is the lower margin of the mandible, and this is the posterior belly of the digastric, and this is the anterior belly of the digastric, making the digastric triangle or the submandibular triangle. And this submandibular triangle is very much related to the facial artery, as it comes from the external carotid, it goes up behind the mandible and then becomes tortuous on the surface of the submandibular salivary gland, and then reaches the margin of the mandible and goes anterior to the masseter muscle towards the medial angle of the eye. Now, where are we? You can orient yourself very well, because you can see the nose and the mouth and the upper teeth, and then you can see to your left the parotid gland, and then you come down to the green marked structure, which is the submandibular salivary gland. Now we know it is in the digastric triangle or the submandibular triangle, and here is what we saw from the inferior surface of the submandibular area. It is the superficial part of the salivary gland, and then this yellow arrow is indicating a muscle that makes the floor of the mouth which is the mylohyoid muscle, and you can see that the salivary gland, the submandibular one, has two parts: a part below the mylohyoid muscle in the digastric triangle, and then at the posterior end of the mylohyoid muscle, the gland extends inside the mouth, and from this deep part, which is the smaller part, the duct of the submandibular salivary gland will appear, and it goes to the both sides of the frenulum. That's the duct, and it opens into both sides of the frenulum of the tongue. This is called Wharton's duct. There is an important issue here. When I say here, I mean inside the mouth, where Wharton's duct is there, and here is the mylohyoid muscle, and this is the duct, the Wharton's duct of the submandibular salivary gland, and here is the yellow structure, which is the lingual nerve. It is in the floor of the mouth, and the nerve hooks the duct from underneath, so it goes underneath the duct and then goes towards the tongue. This kind of relation should be taken care of whenever a person works in this area. Here is a similar situation of the previous slide, where you can see that this is the superficial part of the submandibular salivary gland as it comes towards the posterior margin of the mylohyoid, and this is the posterior edge of mylohyoid muscle, and this is the deep part of submandibular salivary gland, and the duct of the submandibular is going to open into the both sides of the frenulum. Another view showing the major facts about the submandibular salivary gland. What is this? This is the superficial part of submandibular salivary gland, and what is this area here? It is when it turns to get into the inside of the mouth at the posterior border of the mylohyoid muscle. What is this? This is Wharton's duct of submandibular salivary gland, where it opens on both sides of the frenulum of the tongue. What is this image telling me? First of all, what is it? This is a scialogram, an X-ray investigation of the duct system of the submandibular salivary gland, where a fine needle is injecting a radio-opaque dye into the duct, and the duct is going towards the gland, and it shows the very fine ramifications of the duct system of the gland. This slide is left for you to practice your knowledge. It is the floor of the mouth seen from behind, and you can see the hyoid bone, the mandible, and you can see two important muscles, and you can see a salivary gland with its duct, and you can see a relation between an important nerve of the mouth. And please write down your notes on this slide. What is this and where am I? Go and find the mandible. This is the floor of the mouth, where you can see this muscle here, which is the geniohyoid, and then you can see this muscle, the mylohyoid, and therefore anything above it is the inside of the mouth. This gland, which is under the tongue, is the sublingual salivary gland, and here you can see that this gland does not have a single duct, but it has several small ducts that open at the base of the tongue, and they are between 8, 10 or 12 separate ducts. And here is a nerve, the lingual nerve, and that's the duct of the submandibular salivary gland, and here is the point of crossing where the nerve crosses inferior to the duct. Here is an invitation for you to learn more. This is a view of the mouth, and you can see on both sides that there are pieces of metal that is called a speculum, so that the patient keeps his mouth open widely. And you can see that this is the frenulum, and lower down at the base of the frenulum there are two papillae where the submandibular salivary gland ducts open, and this space on the outside of the arch of the teeth is the vestibule. Where am I? This is the base of the frenulum of the tongue, and that's the frenulum. And here you can see that the opening of the right submandibular salivary gland duct, or the Wharton's duct, there's something wrong with it. Something is blocking it, while the left one is looking all right. This is a sciologram of Wharton's duct, and you know now what is a sciologram, and it is an investigation to show the patency of the ducts of the glands. And here the gland has a structure in its duct, and here's the structure, and that's the gland itself, which is surely enlarged. This is a cadaveric image of the mouth and the submandibular area. You can recognize the upper teeth, and then you can recognize the tongue, and you can see the lower teeth attached to the anterior part of the mandible. And here is a gland. This gland is inferior to the tongue, therefore this is the sublingual salivary gland, and that's the tongue, that's the anterior part of the mandible. And you know what this structure is? It is the submandibular salivary gland, the deep part, and this is a nerve coming from the infratemporal fossa, so this is going to be the lingual nerve. What is this image telling me? First of all, here is the sublingual salivary gland inferior to the tongue, and here are the groups of tiny ducts draining the sublingual salivary gland, and here's the submandibular gland, and this is its duct, the Wharton's duct. And then here is a nerve, the lingual nerve, crossing the duct. A quick revision of several parts of the salivary glands, and this picture is left for you to study whatever you can extract out of this image. Here is a very important note. In order that you reach your goal, and that is acquiring enough knowledge to find the disease and beat it, you should do the following, because all doctors do. Ask questions, collect data from the answers, and think about them. Then integrate, share it with your colleagues, and discuss it. Without these 6 processes, it is hard to acquire a profession. Always check your understanding. You check it through sharing, you check it through discussion, you check it between you and yourself. It is understanding what matters. Memorizing is useless. You cannot be a doctor on memorizing information. It needs understanding. And you may remember that Einstein said, any fool can know. The point is to understand. Always try to learn more. Never be satisfied with whatever you have of scientific information. Read the book, your textbook. You have to read it. Doctors read books, no summaries. No, somebody says this and somebody said that. Reading books is important part of your profession. Anyway, you are going to read books whether you like it or not. So it's better sooner than later. This is what books will give you.